I think this is a panel that really doesn't need an introduction. A lot of them are veteran NDTV faces and have actually, championed through COVID times. They've been key in disseminating information, verifiable information that's easy to understand. So it is indeed a privilege to have all of you on our panel today to talk about something, I think, which is, well, I don't even know where to start. Like Vedant said, I think this is one of the most important issues when it comes to our country right now. I mean, if again, I can just put this in perspective as far as statistics are concerned, we're a country of over 1.3 billion people. According to the government's own data, 50% of primary healthcare services available in rural India are 24/7. That essentially means that 50% of rural India doesn't have access to healthcare 24/7. When we talk about healthcare, and especially in the rural areas, I think it is twofold. One is, of course, personnel, which you'd all agree, and one definitely is infrastructure. We'll hope to address both a little bit through the course of our conversation. Speaking of personnel, I think the shortfall as far as specialized doctors are concerned ranges from anything between 60 to 80%, and those statistics are really staggering. The government's own data in 2019 said that if you look at the healthcare infrastructure in our country, 75% of healthcare infrastructure is concentrated in urban areas. Let me put this in context for you. 25% of our population, and these are broad estimates, lives in urban areas. So you have broadly 75% of your population that is living in rural India, which is either not got access to healthcare or have to travel for miles to be able to access quality healthcare. I think this hopefully puts in context why this conversation is so important. Thank you all very much for being here. I want to begin by asking you, Dr. Dang, if I can, because I think when we talk about healthcare infrastructure, it begins with diagnostics. That is key. As someone who is known for providing quality diagnostic care, you're a household name as far as Delhi NCR is concerned. The obvious question that I'd like to ask you is, why can't there be 100 Dr. Dang diagnostic centers all over the country? What are your challenges? Why hasn't it happened?
So thanks NDTV for having me here. Thanks, Rishika, for this lovely question and your kind words. And so I am asked this question very often. And why not scale in a way that you're present in every state and every city? So the obvious thing is that to maintain that level of quality, obviously scaling is a challenge, mainly because of the manpower, like you said. Because now with the kind of technology that we have, and we are very lucky to have the best machines and the best equipment available in India, and also a lot of made in India brands, when it comes to manpower and doctors, even a highly trained DMLT, that's a technician, to get them to go to, say, like a place like a tier 3 place like a Barabanki or a Hisar or a Rudraprayag, where we do a lot of work, is very difficult. And then to retain them there also is another challenge. So actually I was reading up about this, and there was something known as the Dhanvantri Yojana that happened in Gujarat, where doctors and MBBS doctors were actually incentivized that, okay, you go to this city and that's a small town, and then you get this much extra incentive as a salary. So obviously there are different ways, but right, manpower remains as a critical component of the challenges that we face.
Professor Verma, do you want to come in here as the Dean of Academics at AIIMS? You're really at the hub when it comes to personnel training as well, apart from obviously the hub of medical excellence. I want to ask you, where do we start? If we want a resilient healthcare infrastructure, personnel is pretty much the backbone, isn't it? Where do we start?
Thank you, Rishika, and thanks to NDTV for this novel initiative and for having invited me amongst the very eminent people and the panelists. Yeah, the healthcare infrastructure is critically important for healthcare delivery, that we know. And also it has happened in the last so many years, few years. There has been a consistent increase, escalation in the infrastructure building. If we talk about, say, the number of the medical colleges, it's now 700 plus, which is a very significant increase. And also the number of graduates, which has increased to more than 1 lakh every year, the number of seats with the graduates. And so has happened even to the postgraduates also. the number of seats have gone up to the 40,000. But the enormity of the population that we have, the number is still very less.
Sure.
And specifically the shortages of the specialists, the expert doctors, and also the doctors as such. And you were talking about earlier in the previous session. Even the paramedical staff and the nursing staff, there is a shortage. So we need to put emphasis on this as well when we are talking about the infrastructure building. And of course, the government has brought in 22 new AIMS-like institutions in the different parts of the country. But again, the challenge remains that we have the shortage of the experts, the faculty, the trained manpower, technical staff. It's easy to build a structure, but it's so difficult to populate them with the experts, with the kind of people which are needed for those kind of services. But I think a lot is happening in this area, and we are doing pretty well. So if we look at, say, what was happening before the COVID and what has happened after the COVID, we learned a lot of lessons, and also with that, we have also escalated everything. Yeah, if we look at, say, the vaccine delivery for that matter.
Right.
It reached to almost everyone, despite having limitations of the numbers.
Yes.
And
but that brings me to my next question, Dr. Sunila Garg. If you want to take that on, you wear many hats. You're associated with Lancet. You're a consultant with WHO. You understand a lot of these issues from a micro perspective. I'll just take off from what Professor Verma just said, because when we want to do it, we do it. Like the COVID healthcare being extended, like vaccine last mile connectivity. Why do you think that healthcare infrastructure, like I said, to 75% of our population still remains a luxury? What do you think is the main reason for it?
Thank you, Rishika, for having me on the show, and thank you, NDTV. This is indeed a very, very important discussion. Now, let me bring some facts from the public health perspective. Now, when we are talking from the health systems perspective, we need to have a healthcare system which is comprehensive, which is competent, which is compassionate, and which is concerned about its population. So that's where it's all about broadly about that. Yes. And also it has got to be accessible, affordable, acceptable and approachable as well. So there are different A's and C's to it. But let me tell you, post-pandemic, and I'll say that we also, before pandemic also, we had got a national health policy document, which was a guiding document, which also, aimed at achieving our sustainable development goals.
Right.
So I will say that when we are talking about, revitalization of healthcare infrastructure, the government and along with the private partners has really thought into how to go about. And we have got now PM Abhim, which is Prime Minister's, Ayushman Bharat, infrastructure mission, which is, looking into that direction. And primarily we need to see that, under which, already 1,62,000 plus health and wellness centers have been made functional with the availability of community health officer, which, it's a officer with either, staff nurse with a bridge course, and along with the staff and 3 A's, which have already been, have done a commendable job when I talk of Ashas or Anganwadi workers, and they have been really applauded by WHO also in terms of reaching the last mile, not only in terms of vaccination, but also addressing, the healthcare needs of the country, and also filling up the community assessment checklist form that is in concern of non-communicable diseases.
Right.
Because they are the ones who are connected to the last mile, and they are the ones who are connected to our national programs as well. So today I will not say that we are not connected. Number two is that
we are better connected.
Yeah, we are much more connected. 1,62,000, 30,000 plus primary health centers, and then we have got around 8,000 community health centers. This is what I am talking. Every district.
But then, Dr. Garg, again, I'll hold you to that, because while those statistics are government figures, absenteeism is also perhaps one of the big issues. Doctor देखने को ही नहीं मिलता है. We don't have access to the doctor. But how do you fix that? Because like I said, when we wanted to do it, we have done it. We've shown by example with our vaccine program, for instance, that we can do it.
This is what the digitalization has brought a change. We are looking for availability of the healthcare functional. Even if you look from the National Medical Commission's perspective, we do have biometric part. If you want, we can do it. That is where it is important.
Yes.
And that's where, the programs are also, when we talk of TB program, our Prime Minister has given a call for elimination of TB by 2025. It's not just the drop of the hat. It's because, we are performing substantially. We have involved private sector. So that's where, we
Yes.
have done it, and people have got now well-defined roles and responsibilities. And we are also not ignorant of the fact that there is substantial out-of-pocket expenditure,
Right.
where you see we have got PMJAY, where people, families below poverty line are being insured for 5 lakh
Yes.
rupees with the BPL card. So that is another, I'll say that milestone in that direction.
Yes.
Still, we'll say that with 140 crore population, there is a long distance to go. But I'll
Absolutely.
say that with digitalization, with our, indicators, which are obvious, verifiable indicators, we have done a lot. And
Yes.
I'll say that, and our youngsters are very, a big strength also. But then I'll say that through our national programs, we are achieving a lot more.
Yes, and I just want to also highlight, because I began this conversation with glaring statistics that necessitated this conversation. Like Dr. Garg is saying, there have been significant milestones that we've managed to achieve as well. And one of those has been under the National Rural Health Mission. There has been actually a 50% increase in allopathic doctors across primary healthcare centers from 2005 up until, I think this is 2019 or 2020 statistics, if I have that correctly, which is a significant number as well. So, I mean, one doesn't want to discount the progress that has been made, but one definitely can't celebrate progress prematurely. The other big question I want to ask, and this is, I think, something that concerns all of us, and these are questions that I guess everyone's asked at some point. Dr. Mehta, you're perhaps the best person to answer it. At what point do you think private healthcare becomes public, accessible to public, consumable to public? I mean, India's private healthcare infrastructure is so robust. I mean, we have people coming to us from all over the world, but it still remains a distant dream for many people who live in far-flung areas of our own country. How does that narrative change?
No. So you see, if you look at the numbers which other fellow panelists and yourself have mentioned, even today, 60% of healthcare needs are met by private sector, or 50%. So it's more or less, it's there. It's collaborating with the government. It is collaborating and giving service to the public as well. And quite rightly said earlier as well that private sector is very key to realizing any dreams, because you see the country is so vast, such a big population. Here, I would like to mention, public-private partnership is very, very critical. If I were to take example of our own company, Max Healthcare, we have 2 hospitals which are under PPP mode. One is in Mohali and other is in Bathinda, and we are trying to provide the best care to the population at those places. So that's going to be one model that is going to be very key, and which Professor Verma also very correctly mentioned. You see, when you look at in last 6 to 7 years, and I as a healthcare professional can feel it, there has been a lot of emphasis on increasing the number of seats for graduate and postgraduate teachings as well.
Yes.
Like you go to any private healthcare institute which is running a national board examination or the DNB program as well, you have the seats almost double in capacity. But that's just one part of the issue, which Dr. Dang also mentioned. The nurses, the technicians, the paramedics have to be equally trained. Yes. You have to solve the entire puzzle. Just focusing on doctors doesn't help, number one. Number two, India is these, if I could say, we train nurses for the world.
Yes, we do.
So the moment you train, they fly away. So what is the ecosystem we are looking at as a country? So because it's about the quality of life, it's about the financials, it's about everything. You can't hold it against anybody for that matter.
Right.
But the solution is you need to train more.
I'll just put this in perspective. When he says fly away, they literally fly away. Our best trained nursing staff, for instance, is all abroad because they don't have that infrastructure either. So we're literally supplying nurses to the world all over.
Of course, we are. So the issue is we need to train more. Even a place like Delhi, a trained ICU or a OT nurse is a premium. You're talking about tier 2 and tier 3 cities. So that's where, because as the population ages, today we are a young country, 30 years from now or 25 years from now, when we are going to age, the problem is going to be more critical. So the idea or the...
So I'll ask you again, how do we fix this? For instance, the brain drain problem that you talked about. what can be done in order to be able to keep our best people from flying away?
So, the brain drain, as far as doctors are concerned, has been addressed to a decent,
extent,
level.
yes.
Because, of course, quality of life and the financials and other things and quality of infrastructure. So, I think something similar will have to happen. And having said that, again, there are 2-3 very important things. One is, of course, building infrastructure and capacity building. Because the more you train, the more you retain.
Yes.
It's going to be because...
It's a numbers game.
It's the numbers game.
Yes.
So you will always have some portion or percentage flying out. You can't really work on that. You need to work on, like everybody has been pointing out, and digital is going to be a key. Because whether it's digital consultations or AI coming into diagnostics, because primary healthcare, like fellow panelists have earlier pointed out, is the key, and AI can really help us in that.
Right. I also want to bring in a very real life perspective. No offense to any of my other panelists, but we have Dr. Tripti with us, and Dr. Tripti and I connected during COVID, when there was a very, very intimate, very personal experience that Dr. Tripti actually shared on a video which went absolutely viral, which is just her sheer, I think, angst or frustration after multiple hours of work and no sleep in a COVID ICU. Dr. Tripti, Dr. Devi Shetty once said that beds don't treat people, doctors, nurses, and paramedics do. And I think you're a living example of that. When we talk about healthcare infrastructure, and you work in a city like Bombay, where healthcare infrastructure is perhaps one of the most robust that it is anywhere in the country. When that crumbled, when what we had built, what is quality, what is accessible, what checks all of our boxes, when that crumbled, how did it feel? And do you think that we have learned lessons from what happened during that second wave of COVID?
So the second wave of COVID was an absolutely unusual time. It was a disaster. And like many nations across the world, we were also being challenged by the sheer number of cases that we were seeing. Even with all the infrastructure we had across cities, in some ways it seemed like COVID was a great equalizer, but then on the other hand, it really highlighted the inequality in health. Because what we were seeing in cities was like multifold what was happening in the villages.
Yes.
It was also a very, very good reminder that health infrastructure is best built at the primary level. You can do everything at swanky hospitals, but when the primary health infrastructure fails, the entire load falls onto the secondary and tertiary, and which cannot happen. And that did happen in COVID. So it brings us back that when we talk about revitalizing health infrastructure, it really will have to begin at grassroots level. And while there is a great budget for infrastructure, and honestly, the PHCs have lovely areas, they are big sizes. What we really lack is maintaining them. There isn't a great budget allocation or a plan to maintain that, to constantly keep improving the infrastructure. Because if we don't do that, one, we cannot provide what we promised to provide, and two, we cannot retain the health infrastructure. When we talk about doctors not being available in rural areas, that's because they don't move there only to do their job. There's a big background that's required. You require a decent living facility, you require decent schools for their kids.
Yes.
So it requires an entire community which will invite and retain healthcare workers in rural areas. So, of course, that's a long journey. But when we talk about the paramedic staff, we all have, all districts have hospitals.
Yes.
It's not too difficult to start skills building programs or, courses, because when these individuals from the same district are trained there, they will be retained in their own town, in their own cities and villages. And the kind of compassion and the kind of dedication that they will have to serve their own people, it's so much easier than actually expecting people or interns to move from other cities and work for a year and then go back. There is no commitment, and there is no motivation to do that. So it really needs both infrastructure and really planning on how to retain manpower and not just bring the manpower.
But I know there's no yes and no black and white answer to this, but do you think we've learned lessons from, say, your own experience of what you dealt with? Do you fathom it will be better, God forbid, if we find ourselves in another situation like that?
I think we've learned our lesson. I think we've moved in the right direction. India focused on roti kapda makan.
Yes.
Then we went to bijli pani sadak. The fact that we are having health conclaves
Yes.
is such an important statement. For a major media platform to talk only about health.
Yes.
COVID did really bring health in the discussion in living rooms. People were talking about health. People do understand preventive health so much more than what they didn't until COVID. So COVID just fast forwarded all those aspects for health.
Health became a household conversation. I think that's something that COVID definitely did for us. But Dr. Sunila Garg, I want to bring you back because you really understand how different health programs have been implemented across rural India. But I'll come back to my question that I asked you last time as well, which is what is our big challenge? I mean, if you look at the FAO report that came out a week ago, it still said a staggering 74% of Indians don't meet nutritional requirements or can't afford a healthy diet. Let's put this simply. I'll also put this statistic in perspective. It's a 2% improvement from the last year. So, it's important to look at numbers in some kind of context as well. But, when you're dealing with an average of 70% people not being able to meet nutritional requirement, I mean, medicine is like unthinkable for them. How glaring is the situation? How staggering are these statistics?
I think this is a very important question also, and I'll say that from a public health perspective, I'll say that, more important is if you go into the micro level.
Yes.
So now you know that after portion 1, we have got portion 2 also, and then we also have huge burden of anemia. Like 57% of our women are anemic, to talk more about, our adolescent girls are anemic.
Yes.
And then, our boys also are anemic to the tune of 23%. But when we talk about, its, availability and all that, more important is also that people who are living in cities also, or, better to do citizens. I'll say that it is not the affordability of food, but it is also the healthy choices of food which people have to make. And this is where,
No, but here we're talking specifically about affordability because of the cost of living index that has gone up as well. So these are all very real problems.
So that's where we need to kind of, have awareness at the last mile, and we need to also look at the micro level what all things are being done. Like particularly when we are talking about, our biggest chunk of our population is also our school children.
Right.
So we are talking of healthy school concept. That doesn't mean only talking about their health, but making them do really in terms of growing, kitchen gardens and all within the school settings. And also, have the best of each state. Each state is very different. Each state is very diverse.
Right.
So, we talk about crops. We talk about better availability of crops. You see, health cannot be talked in isolation.
Absolutely,
or availability
which is why I brought up this question
food.
because this is so linked to the healthcare
You see,
infrastructure.
when we talk about, involvement of food and agricultural organization, or we talk about health, or we talk about education, everything goes hand in hand. And that's why, earlier when we brought about the, pictures of, or figures of stunting and all, that is where, we had to relook at with the help of Minister of Women and Child Development. But the answer is not so simple. I'll say that, it's not only we need to make availability of food, which is India is also exporting, a lot of, food outside as well. So that's where we need to kind of create awareness with regard to locally available foods, which people can consume. And also, their habit of, having, particularly we need to look more deeper into the food practices also.
Yes.
And we also need to kind of involve self-help groups within the community to talk about. And also great role is of Panchayati Raj institutions, which are institutions by themselves.
Right.
So it's not only that we kind of talk in isolation, but we need to take
all
these
of these
together.
different factors into consideration. I think that's absolutely correct. Dr. Mehta, if I can come back to you, because one part of healthcare infrastructure is creating and building. And that is happening at quite a rapid pace. If you look at, the speed at which announcements for new All India Institute of Medical Sciences facilities in Tier 2 cities are being made, or the proliferation of, bigger hospitals, better diagnostics in different parts of the country, I think there is definitely a renewed focus on that. But when you're talking about revitalizing health infrastructure, it's also about the maintainability. We've addressed the personnel part of it, but what about sustainability and maintainability? Do you think there's enough thought that is going into that? As someone who understands this space on what it takes to actually create, build, but then also sustain and maintain, do you think enough is being done?
I would say yes. I think, like I said earlier, if you look at in last 5 to 7 years, a lot of emphasis in almost doubling our training of manpower. That's just one part. And what Madam just rightly mentioned, you have to look at the entire ecosystem. It's just not just one part. So I think with the space, whether it's public or private hospitals which are coming up, the most important and the critical component is going to be maintainability of the healthcare professionals, how you are able to train and retain at the local level. That's going to be the key. You see, India sorted out its medical issues or the treatment issues in last 25, 30 years by ensuring you have doctors who got retained in the country. I think now that has to be done at the city level.
Yes.
So once that happens, I think we are in the right direction. It's going to happen, and that's going to be the key, because building is easy.
Yes.
Maintaining is the key. The second part is going to be the quality, which our first panelist, just mentioned, because getting the right quality and ensuring that they stay with you long enough to serve that population, that is again going to be train local and retain them is going to be the keys. But I think we are on the right track.
But I think when you talk about quality, there is one particular aspect of health infrastructure which I think is the most underscored and less spoken about, which is how do you deal with quacks? How do you know that the advice that you're soliciting, whether it is diagnostic or whether it is curative, palliative, across the board, how do you know that the advice that you're getting from a particular medical professional is actually verified and you're not falling prey to a quack? And this is, I think, Dr. Tang, if you'd like to take this on, I think this is also a very typical rural healthcare infrastructure problem, because in the cities across the urban network, you have trusted names, brands, big hospitals, known hospitals, government hospitals, more accessible at a larger scale. How do you think this issue can be dealt with? For anybody who says, I can perform an X-ray for you and I can do a blood test for you, how do you test whether that person knows what he's doing?
So, Rishika, this is very, very relevant, and it's really disheartening, but we do get patients who travel to Delhi in search of a final diagnosis when they've been to pillar and post. And it was only a few days back, and there's this very humble family, and the lady's been coughing since months, and they said कि इन्हें बोला कि tuberculosis है. तो one of my doctors met them. They said, अच्छा भैया रिपोर्ट दिखाओ, फिर हम आपको आगे गाइड करेंगे. And they're like, नहीं सर, हम तो पहलवान जी के पास गए थे, उन्होंने हमारा बलगम एक सलाइन बॉटल में डाला और फिर उन्होंने उसे ऐसे देख के बताया कि ये तो टीबी है. So actually she has something else, and she has COPD but not tuberculosis and doesn't need that ATT for it. And so I completely agree, but Rishika, what we must keep in mind is that these quacks who come up are basically because of the huge need and the less supply that is there in non-metropolitan cities. So it's like a chicken and egg. If you don't have the accessibility to good healthcare in these tier 2, tier 3 cities, obviously the quacks are going to come up. So from a more bird's eye view perspective, I would say that we definitely need a legal framework for this, where anyone can be punished for doing such activities. Also, education and awareness. A chain is only as strong as the weakest link. So as long as people understand to be aware and to know more about basic health issues and when to actually address them, I think we are moving towards well care rather than having someone sick and then going for care. So from sick care to well care is what prevention and such screening tools and prevention of these quacks is going to lead to.
Right. Professor Varma, do you believe in a certain sense that proliferation of, say, the All India Institute of Medical Sciences across, different parts of the country, there are so many new initiatives that have been announced. Do you think that will, in a certain sense, grant some sense of legitimacy also when it comes to, what type of healthcare you have access to? How do you deal with this problem of quacks? How do you deal with fake doctors out to dupe people to make money? Because I think it is one of the less spoken of problems when it comes to our healthcare infrastructure.
Yeah, absolutely. I think that is one of the major challenges that we have in our country. And as the fellow panelists have said, that it's because non-availability of healthcare professionals, the trained ones. So people have they go to whosoever is available. or who claims to have known something which they can trust, and they go with the trust that is probably they're going to be all right. And it's not just the unqualified people who are advising people because of the non-availability. Even the people who not appropriately qualified are also advising on many issues. Like sometimes the pharmacists advising
Yes.
the public when the person takes the prescription from the doctor. And then the pharmacist, he starts advising on the prescription of the expert and telling him that, okay, this is right, this is probably not right.
Yes.
Don't take this much, take this much only. If you take too much, there is a problem. Or maybe do not take it for that length of time. Maybe shorter duration of the treatment is also all right. So there are issues. And these are basically, people need to be educated as to how they should access the healthcare facilities and whom they should contact or whom they should speak to or whom they should meet for their problems. And the quacks, again, it's a big problem. But the problem is, again, because of the non-availability, as we have said. Once we are, say, approaching and we are increasing our health infrastructure, the manpower, and the availability of the doctors, the paramedical staff in the periphery, where the availability of qualified health professional is a challenge. I think this issue also, and the regulation is another aspect. Okay, you want to regulate,
Yes.
it should be. It should
Yes.
be regulated as to the people who are not qualified in a particular kind of, say, profession, or
Yes.
they not supposed to be advising, they should be regulated. But where do they go? That's another problem.
Right.
So we
Where do they
need to
go?
meet that. Yeah, where the people should go?
Right. There's one last crucial aspect of this conversation. I'm told I have 5 minutes left, so I'll be really quick, which is, of course, investment into infrastructure. And I know that you all have all agreed on the fact that, it's the structures are welcome, but they are not the most important. It's the personnel, the manpower, and the proliferation of these personnel to different parts of the country that's actually going to lend itself to some kind of solution. But just purely in terms of, how our equipments, etc., work right now. I'm no expert, so I'll take it to the experts very quickly. Dr. Dang, do we have everything that we need, or are we still looking west for the most sophisticated equipment, or can we now proudly say that yes, India's reached a point where it may be exclusive and it may be restricted to a few centers, but it's there?
So Rishika, there's a proverb that goes by, a 1,000-mile journey starts with a single step. But I would reframe it and say a 1,000-mile journey starts with a single step in the right direction. So obviously it's not black and white, my answer. But yes, we've made leaps and strides in the right direction with a lot of good equipment, technology. We have it all going for us. But obviously, I don't think we should shy away from actually collaborating with international partners, getting that tech transfer here, learning from them. Like, I'm very proud to say, like, when we launched the first drive-through in India, I took that idea from the West.
Yeah.
And I loved it because it helped so many people here. So I guess that collaboration is key, learning is key, humility comes with learning from others and then giving it to the masses.
Dr. Mehta, would you agree?
I think absolutely. Not only equipments, I think most of our research we owe it to the West. So there is no question of not collaborating. We must, that's the right way to go. But having said that, I think most of equipments today is the high-end ones are all imported. That's a fact of the matter.
Yes.
But I'm also told
So we have some bandwidth as far as Make in India equipment is concerned, I think.
I think we're getting there.
We're getting
I'm told that the first Indian-made MRI is now available in the market. Till now, it's all been imported. So I think something now we take for granted in cities like Delhi that every hospital is going to have an MRI.
Okay.
So I think we're getting there in the right direction. So
Dr. Garg, final
Yeah,
comment.
I'll say that now we have got Indian public health standards. I don't know how many of you are aware of that. And as per that, we decide our equipments, we decide our manpower, we decide our medicines which are going to be available.
Right.
And the last was available made just as soon as 22. So
Okay.
I'll say that, we must, focus on not only world is one. We are small. Now, interchange of technology, whether we talk of research.
Yes.
Now, whether it is operations research or whether we talk of implementation research, When we talk of product development, its implementation and its delivery. Now we have gone far ahead. You see, that's where we have to understand our systems. And in between you talked about retention of manpower. We have to understand that there are huge differences between government and private sector as far as salaries are concerned.
Also,
the employee, within the government sector, if you talk of multitasking person, there is a huge difference between the salaries. Coming to nurses and all that, you must see that whether we are able to satisfy them, so they are able to make decent living, and we have to see why Kerala is different or Tamil Nadu is different as compared to Uttar Pradesh.
Absolutely.
Because of the total
we have to give them
campaign.
reasons to
So
stay. There are no two ways about it.
Yeah.
Dr. Tripti, final comments.
So I think healthcare is a right, and I think our infrastructure really needs to mirror that, and it really needs to begin from the grassroots level and then go up.
Yes, I think that point that you made even earlier made a lot of sense. And I began this panel by talking about the state of primary healthcare in India, because that is where the problem starts, because it is that burden that then carries forward to our cities, to our urban healthcare infrastructure. We have it all. During COVID, during the vaccination program, we've also shown we can do it. So I think there needs to be a collective will. And like you rightly said, I think the boundaries, international boundaries, political boundaries, state boundaries, they all blur when it comes to healthcare. The world really has become one post-COVID. Thank you all very much for joining us. We're all richer after talking to you all, and so many different perspectives on revitalizing India's healthcare. It's indeed been a riveting conversation. I thoroughly enjoyed this. I hope you did too. Thank you.